So after a long time, once more we meet up.
It's great to be here, Ben.
So personally, I'm very glad to be part of this panel, excellent panel actually. Experienced surgeons from across Badr Samaa group of hospitals here assembled to discuss a topic. So today our conversation might be confined to, I think, a very small part of the body, the bottom, where people come with large numbers with problems related to, passing stools. In my 2.5 decades of practice, I have seen as much as 20 to 30% of people coming with some problem related to bottom. So it's not a small issue as far as the public is concerned. So for the benefit of the public, let me put it like this, in the sense that for the public, unfortunately, anything and everything related to bottom are called piles. But for us, it is slightly different, as we all know, that there are at least 3-4 entities which come with problems in the bottom. For example, it could be a pile, it could be a fissure, it could be a fistula, it could be an abscess. So these are all problems that can come up in the bottom. So to start off, can I request you, sir, what is piles? Like, what is piles and why this is so common in the society?
Yeah. So thank you so much, Dr. Sukumar, for that wonderful introduction. And it is indeed very important to know that when especially we are encountering problems of bottom, and every patient who is having any problem related to bottom, be it pain, discharge, swelling, anything, they consider it piles or bawasir. But on the contrary, as a medicine person, we know that there are different variety of problems which can exist, and something can be very alarming also. I mean, things like cancer also happen to that area. So precisely to understand piles is nothing but simply a prolapse of mucosa along with venous plexus, along with vein, which are there in the anal canal area, right? And it is basically nothing but simply, there can be n number of reasons, but the most common reason is our dietary practice. Prolonged constipation, if somebody has to strain for some or the other reason, sitting practices. So all these things contribute. I think those are the areas which need to address and understand how we can optimize, how can prevent, how we can prevent all those things. And since we have people like Dr. Deepak, who is probably the senior most person in Badr Samaa group of hospital, and to all you, this is very important to know that we have a stalwart like Dr. Basant Sahu, who is probably the beginner, senior most person in Oman per se.
Sure.
So let us hear from the voice of Dr. Sahu, is there any something like seasonal variation during festival time like Ramadan? All these factors, do they contribute at all to the bottom problems? Do we have any increasing change in OPD whenever, especially after Ramadan or during Ramadan? Sir.
Thank you very much to Dr. Prasad to tell me. It's not on the senior basis we are here. We are here to give the proper information to the people that what we are doing, it doesn't matter who is practicing where. It's a common thing for our group of hospitals to manage the problem wherever available. Whichever is the best to do that, we are going to provide that. That is the main aspect of our group of hospitals position.
You are right.
So on that way, you are right. Ramadan is a time where they fast for a long time, and then they all of a sudden go to eat food after some time. So there is a change in the food habits, which perhaps, and they don't take a lot of water. Another thing, the whole day they are not taking any water. I think much of the water. Is it?
Yeah, they cannot.
They cannot. Yeah.
So the 12 hours of not taking water is quite
in fact, more than that.
More than that. That makes the definitely the bowel habits more constipated, or also the food habits again. If you take most of the time now, the present situation when we go for our new generation of people, we are using a lot of vegetables and all those days. Now with the new standard food habits, they get proteins, which is no residue. So unless you have some residual food like vegetables or which can come and keeps the bowel to empty, that is the main cause of our problem now, what we are facing now. Whether it is a festival related or daily lifestyle problem, like a office goer or like us, we come to the hospital, we don't take much of things, then go back, okay, have somebody, we take some meat, fish or whatever the proteins, but the vegetable amount becomes less.
Some quick foods.
And quick food, and which is no residue. So that is the main cause of the problem perhaps now we are facing because of the anal. It is not that the anal problem was not there before. It was there. But I think the more it is happening now. And also the cancer, the incidence of cancer perhaps increasing because the bowel is not functioning properly. And also the organisms in the bowel, they are not growing, the commensals. So if they are reduced, so they are a harbinger for the other diseases. So I think these are all coming down to that factors. So I think you are right. In the Ramadan also that will happen. And the other signs also the lifestyle, food habits and all those things, which causes this problem for the anal problems. So like mostly these are related to, you can call the piles and fissures. The other things are related complications of those two things. So going to the abscess or fistula, they are complication of these two things. So what I feel that way.
I mean, that was a wonderful piece of information from Dr. Sahu. And like he rightly mentioned that dietary fiber and hydration, these two are the key factor for avoiding constipation. Yeah. I would like to ask Dr. Deepak, is there any change in the pattern of patients who are coming during and after Ramadan, especially related to bottom problems, sir?
Like doctor has already described, the basic problem or rather the basic reason why these things happen is constipation and passing hard motions. And I think the public requires to understand how this constipation is causing this hemorrhoids.
Exactly. Yes.
So to put it in a simple way, I think all of us, all humans have got something called as anal cushions in the anal canal. Now these anal cushions can basically be likened to, sponges filled with blood. And they have an important task in that it is acting like something like a washer in a plumbing. It prevents leaks. So when an individual is passing flatus, you don't want motion to be leaking. So then that is what nature has given us so that we don't leak. So when we have prolonged constipation, the pressure within these anal cushions go up and they tend to become bigger. And over a period of time, especially for people who have the habit of reading newspapers in the washroom or, getting up to date with their social media status on the washroom, prolonged sitting on the closet is one of the reasons why the supporting tissues of these anal cushions become loose. So this is what causes the anal cushion, so to say, to become bigger and to start prolapsing outside. And that is when the problems of hemorrhoids and bleeding and everything starts.
So if I may put it in a slightly different way,
yes,
it has a lot to do with the pressure that is applied on the anal region.
Exactly. Yeah. Exactly.
A lot of constipating diet, a lot of hard stools, then straining a lot. Over many years, it really produces a lot of prolapse. That's what probably the public should understand.
Absolutely right. Yeah. Absolutely right.
During Ramadan, what happens is, for the majority of the time, the public are not eating food. so nor are they drinking. And what happens is, during the time when they are eating, it is more on non-veg food, and the fiber content of the diet does come down. And like doctor already said that it causes a bit of constipation, yes. At the end of Ramadan, what happens? It is celebration time. It's something like
Yes.
people overeat again. Again, it is non-veg food which is overeaten. So like that, we do have a increased incidence of, acute fissures and bleeding and all soon after Ramadan.
Do you think it is to do a lot with the lifestyles?
Of course, yes. Of course, yes. In fact, Dr. Sukumar, I was about to ask the same question to you actually. Ramadan have over and the summers are nearing. So what is your take regarding maintaining a proper hydration in a common person? How do they manage? I mean, is there any calculation, a quantity, like how much water he's supposed to take? And is it only a water or he can take any liquid?
Yes.
Yeah.
See, I think it is a primary responsibility of each and every one of us.
Yes, as a healthcare person. That's right.
To keep our bowel motion as effortless as possible. So definitely, as you rightly said, hydration plays a huge role. And if you want to quantify how much you should take for 24 hours, maybe roughly 2.5 to 3 liters per day. That's what I understand. So often we don't do, we doctors don't do that, do we? I don't think we, because it should be an effortless process as part of our day-to-day life, that we keep a little bit of water by the side of our seat, so that we keep sipping water every hour, probably a glass, a cup or something like that. Maybe that will suffice.
Yes.
And also, second thing, as we already discussed, what should we eat? We in general, the public is taught to eat a lot of meat. A lot of, it's not that meat is bad. Meat is definitely good, it is required. But when you don't balance meat intake with adequate fiber in terms of vegetables, salads, fruits, then there is a problem. So if you eat this much of meat and non-vegetarian, you should compensate equally with an equal amount of a quantity or a sufficient quantity of fiber, high fiber diet like vegetables and fruits. So that's my take on that.
That's right. That's right. So as a common practice and for the benefit of audience, I would like to add a few words to what Dr. Sukumar have said. I mean, this is as per my understanding. A 50-liter man has to consume 5 liters of fluid until proven otherwise. And when I say fluid, it means everything, whether it is a buttermilk, whether it is a cold drink, tea, coffee, plain water, anything in liquid form which you are consuming, even if it is a part of your normal curry or a meal, that is fluid for me. So a 50 kg man, 5 liters, 60 kg man, 6 liters, 80 kg man, accordingly. Plus, whatever the quantity of food which you are consuming, let's say 250 gram of meat you are consuming, ensure that 250 gram of green vegetable you should also consume. So you have to neutralize and equalize the concept of consuming fiber and hydration. This is what my understanding, although it is not mentioned in any of the literature, but in my more than 2 decades of practice, this is what I have advised to all of my patients, and whosoever is following it, believe me, this works. It works. This is as per my understanding.
The other importance of hydration is the consumption of fiber is important.
Yes.
But for the fiber to cause motions to go soft, the water is required.
Water is required.
The absence of water, the fiber doesn't do its
Doesn't
thing.
do it.
That is more important.
So add to all these things, excellent discussion. So the first thing about the pressure, you told the pressure. It is one of the factor. All that is. There are other factors like in a fissure. If you have a fissure, acute or chronic, so that causes a spasm.
Yeah.
The spasm, as you know, anatomy. See, it's a direct artery to the venous anastomosis there. Like 3 o'clock, 11 and 7 o'clock we tell. Right is divided, left is not divided. So 3, 7, 11. That is the main area where the vessel is coming and going. So when there is a spasm in the muscles, the first thing will be the soft vessels is the vein.
Absolutely.
So the vein See, the arterial flow is there because that pressure is not enough to cause artery. So the artery flow is going, the venous flow is blocked. So that is a distension. Therefore, they immediately they get burst. Then after some time, bleeding stops, and they are horrified. Yes. Why they come? Because they think the blood dropping means they are horrified. Everybody is horrified. Why the blood?
Of
Even
course,
a little blood. Unless you see whether there is a piles or fissure or something, we cannot rule out unless, like recently, I had a patient 3 months ago. One patient came as piles. So I just took it for the UA. I find there is a growth.
Yeah,
That's right.
And he was bleeding heavily. So, and the growth is you cannot reach by the finger or the scope. So I took I told my gastroenterologist, okay, come with me, and we put it. It was around 10 centimeter above.
Yeah.
And it was a growth, and so that patient has malignancy. And this is a patient who is 35 years
So
old.
probably what you're trying to say is anything should be
properly evaluated. It should not be taken as casual.
Yeah.
A patient comes with thing, it should be like sometimes patient comes, no, I don't want to see if a lady, you are a male doctor, they will tell, no, I don't want to be examined by you. But there the problem comes. Then I have told my gynecologist that you see that. Same time you call me. So that when you call me, you are seeing that.
Yeah.
So that takes the away. Where we have
to comfort the patient.
Comfort the patient
And
mostly.
privacy is everyone's right.
Everybody right. Even a male patient.
And we have to respect that. Even males have their own privacy.
So these are the things. So the pressure, again, that I am telling you,
Yes,
the
sir.
pressure is not only because of the food habits, also because of the pathology there.
exactly.
So,
If I may come back to the point,
Yeah.
Yes.
public is still not clear about what is hemorrhoid and what is
what is
fissure.
yes?
So
Yes.
let me make it a little more clear
Yeah.
for their benefit.
yes, sure.
Like fissure is a different entity from hemorrhoid actually.
Yes.
Fissure is something, as Sir rightly said, has to do a lot with the muscle tension around the anal canal. There are two muscles, one smooth internal muscle and one
external.
very external muscle. This internal muscle is not unfortunately in our control. So when it is hurt, it will go spastic. And when a hard fecal matter has to pass through, negotiate this muscle, it definitely hurts and produces the so-called giraffe.
Yes.
That is what is called fissure.
Fissure.
When it becomes a chronic problem, we call it chronic anal fissure, which is by definition more than 8 weeks standing, I think.
Yes.
Yeah. So this is another problem which is much more troubling to the patient than hemorrhoid itself.
And it's troubling to the doctor also.
Also, yeah.
Because the treatment is,
It is more
they come
difficult
now,
to treat actually.
they think that if you do the treatment, they will be cured. I always tell, no. This treatment is what we do is to relieve the cycle, close the
Yes.
cycle. But the cycle is like come back again. If you have that food habits and all those things not
So
go back.
lifestyle modification is again the key factor.
Same thing.
actually.
So we are trying to break the cycle by doing some post-surgical procedure, whether you do injection, whether you do a hysterectomy, whether you laser ablation, whatever. So that is the way just you break the cycle so that it heals and you get rid of that chronicity.
If Dr. Deepak could elaborate on the presentation, so when people should think of hemorrhoids and fissures, then that would be better for the public.
The way I advise my patients is, this is not all inclusive, of course, but in case there is painless bleeding, it is more likely to be hemorrhoidal issues. And if it is, burning sensation, pain with minimal bleeding, especially which is kind of streaking on the motions which are passed, that is more in favor of a fissure. And the thing is, the differentiation between acute fissure and chronic fissure is also important, because what the patient should understand is the acute fissure, the pain is because of the fissure itself. But in chronic fissure, the pain is mainly because of, like what the doctor has said, is because of the sphincter spasm.
Correct.
So that is, and once the sphincter goes into spasm and hypertrophy, the chance of medical treatment becomes less and less effective.
Right.
So that is where the role of surgery comes into the picture. And my dictum that I follow is, especially in the case of chronic fissures, is when the patient tells, doctor, do something, the That is when we know, okay, it's time that so because
He
the
needs
pain
some
is,
intervention.
yes, the pain is so severe that the patient is frightened to go to the washroom to pass motions also. That is the kind of stage where you know that, okay, medications have got no further value.
And sometimes also we have to tell them this is not the cure for this.
Yes,
That is
the
because a
importance
lot of the
lies that
time they think they come back or tell, oh doctor, you did it and happening. So we don't want to listen to that.
Yeah.
We have to tell them, no, this is the fact. You are the doctor. I always tell them. I am not with you always. You are the doctor. What is your diet? How you do take care of the most of the time I give them a seize bath.
Yeah.
They tell, oh, what you want? I told, for me, clean water, warm water is enough. I want to do this. I told that is, I don't, your choice, but I don't advise because some people are irritant to the chemicals.
Yes, yes.
So it's better not to have it. What you are doing is a cleaning. It has nothing
Just
to do with
mention
it.
my point in that,
Yeah.
sitz bath. Sitz bath, I usually advise people to put a lot of salt because salt is something which has got a lot of osmotic action so that it really reduces the edema around it. That's one thing. Second thing is that salt by itself totally alters the environment there so that bacteria can no longer survive. You know, that's my take on that. So
Yeah.
these are two things which is probably a salt sitz bath will help.
That is, they ask, the patient themselves tell, will I put salt? I told, yes, you can put salt. Because when you put salt, it has a hyperosmolar becomes, it will break the cell walls of any bacteria or anything, according to the physiology, isn't it? So it's a better way of doing. So main thing is the cleanliness is very important in that area. The seize bath, mostly, I always tell them in an acute case to go for this. Even a piles with external thrombosis or something, I will come back to the thrombus piles also, which is another problem which mimics with so many things with when the patient comes. So I think that will be better.
Yes.
You can go with the thrombosis, thrombus piles and
Couple of things to Sir's sitz bath using salt with hot water. Presence of active inflammation or wound will always be a limiting point. And whenever a patient is approaching us in the OPD, he is having some or the other form of active inflammation or ulcer. So that may be one limiting factor for using salt. Otherwise, if somebody can tolerate salt, that is a wonderful thing. My question will, Dr. Deepak sir, remain unanswered.
Okay.
The sir interrupting between. I mean, there are plethora of medicines in the
Yeah.
market.
Yes.
And every patient, whoever is visiting to our clinic, is expecting some or the other kind of magic with the help of medicines, right?
Yes.
We all understand that lifestyle modification is the key factor of having piles or no piles or constipation. So, Dr. Deepak, what is your take on all the available medicines? Is there any medicine available which can actually cure piles? Let us.
In my experience, what I have found is small degrees of hemorrhoids which are not bleeding, but which causes only kind of an irritation, and which is diagnosed by a proctoscopy by the surgeon. There, the role of lifestyle modifications, of course, is a basic common minimum. There is no compromise on that aspect.
Even
at all.
after treatment, it is.
Yes, after treatment, before treatment, whatever.
Yeah.
That's a basic common minimum program, like so to say. The medicines will have an effect in these kind of cases where it is a very early thing and there is no bleeding, there is no much of prolapse also. But having said that, it has to be on a follow-up basis. And I don't think that these medications have a cure per se. It is basically that it may be under control and it might prolong the period whereby the piles increases in size. But a cure, I don't think, is possible with medication.
So if I may add to it, like medicine, the question was about medicine.
Yeah.
See, there has been an anatomical aberration.
Yes.
Hemorrhoids is an anatomical aberration.
Yeah.
It has happened already. Like a hernia, for example. What on earth makes you treat a hernia by medication? It's impossible, right? So hemorrhoid also has happened. maybe it's first degree, second degree, third degree, fourth degree, even fissure has happened. The irritation continues again.
That's
So,
right.
how to tackle this anatomical aberration? Is it possible at all with any medication? You can only prevent progression of the disease.
Yeah,
to higher
that's
extent.
exactly what I meant. Well, the idea of medications is to, prolong, for example, prolong the progress of the disease from grade 2 to say grade 3.
Exactly, yes.
That is the only thing.
A reverse
That is
It's
also
supposed-
a delay basis.
Yes.
Yeah, suppose medicines were not taken, the progression might be say 1 month. If you take medications, maybe it might be 2 or 3 months maybe.
Yes,
That's the only thing.
exactly. So,
Like I said, it's not curable.
Then coming back to the pathology, what happens actually here? There are a lot of innovations recently in proctology, as we professionals we talk,
Yes.
which public should also understand. I
Yes,
think
yes.
traditionally it has been injections, cutting, and unfortunately, it's very sad to say, the disease has been painful for many centuries. Okay, even the treatment has been equally painful for the public. As you know, Milligan Morgan hemorrhoidectomy for 2-3
2-3
months.
weeks,
patient
yeah,
is in
it's very
trouble,
painful,
real
very
trouble.
painful.
There is a wound, there is bleeding, there is irritation, and life is troubled. Day, nights, all spoiled. So there has been a lot of innovations recently. How the treatment of piles could be made free from wounds, free from pain. Just like you do a hernia, come to hospital, do a hernia, get stitched and go back to work maybe in another week.
Yeah.
So there has been some, in my opinion, there has been little revolutionary intervention that has come up recently regarding treatment of piles especially. For example, the better understanding of the pathophysiology, what exactly happens with piles. There has been an increasing understanding about the blood, the vasculature role in the genesis of piles recently. And in tackling the piles, the anatomical aberration called piles, people are now more and more targeting on the inflow of blood into the pile mass.
The main thing.
Okay, so instead of the traditional cutting and making a wound and then make the patient suffer for 2 months, 3 months like that, now people are focusing on
Devascularization.
ligating the blood vessels which supply the piles. There are any number of techniques available, and a few we'll elaborate later. And what's your take on that?
You're absolutely right, sir. I mean, almost for last 3 decades, forget about piles, the entire surgical practice, we are mainly focusing on minimal invasive, because that is something which can ambulate patient on early. So is true in case of proctology also. Last 5-7 years has been quite revolutionary in terms of coming of procedure like laser and a stapler, closed hemorrhoidectomies, hemorrhoidal artery ligation, and couple of more. Worldwide, almost half a dozen procedures are in practice, and surprisingly, everything has got a more or less similar efficacy and outcome. This part of the world, we are mainly focusing on stapler and laser. Other than that, there are few other procedures which Dr. Deepak would like to tell us more about it.
What I'm doing basically is I'm not so much into laser, but I do stapler hemorrhoidectomies. Yeah, but the stapler hemorrhoidectomy cannot be done for all kinds of hemorrhoids. The patient selection is very important, and if you do it on a wrong patient, then the results will be very poor. So proper patient selection, it's a very, very good procedure to be done. I would say almost painless to that extent, and less than a week the patient can be back to work if it is done in the correct kind of patient. The other techniques, I think doctor could elaborate on it, please.
Yes, Dr. Sukumar, what about it?
Yeah.
Like, for example, imagine a situation where a patient with a painful hemorrhoid, or even otherwise a hemorrhoid, walks into the clinic and then requests cure for it, and then walk away back to home the same evening and back to normal life the next day. So I was just imagining until a few years ago whether there could be such a treatment or not. But fortunately, yes, it is there. Definitely, it is there. It's a good news. It must be a good news for the public of Oman also. It is being practiced for decades in India. Like the so-called very recently passed away Dr. Shivate. Yeah, I would call it one of the wonderful innovations made in proctology, especially but such a gift by Dr. Shivate before he passed away. It is called the so-called Shivate's procedure, with a simple modified proctoscope. We just put 2 layers of sutures around the anal canal or maybe the lower rectum or so that we completely devascularize the entire pile mass in a matter of a few minutes. And because these sutures are put above the so-called dentate line, there is absolutely no pain for the patient. And the interesting thing is that the result is demonstrable on table. Even the 3rd-degree hemorrhoid, once you complete these
Shrinkage happen then in there.
yes, on table there is an absolute shrinkage of hemorrhoid, and the complete result is evident in 2 weeks' time. So the patient goes back to normal life the next day. So this is a very interesting and promising method of tackling hemorrhoid, I believe.
Yeah, good. There are a lot of things are coming because of this, that you can, it can be a daycare surgery for everything.
That's important.
As we are coming to mostly a daycare type of surgery, like the gallbladder, even sometimes I do in the morning. If the patient wants to go home, I told, okay, go. There is no pain, what should I do? So same thing, the hernia. So it depends upon the types of piles. Above the dental line, whatever the procedure you do, it will be painless.
Yes.
Okay. So when it comes to the below the dentate line, that is the problem. So whatever you do, there will be some amount of pain. So yes, we can go to the targeting the vessel. That is the most important. Targeting the vessel is important. If you block that vessel, that's finished. That reduces everything, because there are some other circulation which can go, which is not cause that anal cushion problem. So we have from the below the dentate line vessels are there. So another thing I was coming, which we are the perianal hematomas, which is not mostly is a rupture of the vessels, outside vessel below the skin, and that is very, very painful, because it is below the dentate line below the skin, and sometimes you have to, if it is a bigger one, you have to go and evacuate, otherwise the patient cannot bear that pain. So these are the things. So whether you target by laser, whether you target by the sclerotherapy to the artery, or by ligating directly, or go by endoscopic
Doppler, maybe
Doppler and target the artery and put the
yes,
block that. So these are the things coming up nicely. So when it is a complicated piles, like it is internal and coming outside, where we got a thrombus piles, we tell, it is coming down and extending below the dentate line and cutting the pain, because otherwise pain will not be there. Piles will never be painful unless it is below the dentate line. That is the basic thing, because it's a cutaneous supply. That is a visceral supply, so you don't get visceral pain. So these are the things we mainly think. Most of the time I have seen that whether I do a laser or open, even open, my procedure is more or less same. I go and ligate the pedicle directly. I go to a submucous dissection of the piles. From the dentate line, I go, do a submucous, take the whole vessel, go up to the pedicle and ligate the pedicle there, and then finish. So in that case, perhaps the same thing, it's above the dentate line, you don't get much pain, and I have seen patients having no pain. In the laser, the advantage is that the pain is for immediately you do in the morning. Evening, the patient will come, sir, can I go on? I told, okay, you go on. That is the difference between the, even you are doing it below dentate line also. Because what I do, I go above the dental line, put the laser subcutaneous to the below the dentate line, so that there is some amount of laser coming, which is already I have blocked the main vessel by the laser ray, whether it's 7 or 11 or 12. Sometimes I do it in the fissure also. If the chronic fissure is there, same time ablate the fissure that same time. So that reduces the pain in those patients. I don't know you people what the
Because you talked about patient experience.
Yes.
Let me narrate a story.
yeah.
One of the first laser cases which I did some time back, the patient has been driving to the hospital from 200 kilometers away, and we did the surgery in the morning. By evening, the patient wanted to go home. Yes, of course, natural. There's nothing. The patient has had no pain. He only had some anesthesia, and then that's over. And then, what happened? The patient wanted to drive back alone himself 200 kilometers the same day. That is very interesting, right? Again, the Shibata procedure, the so-called transanal suture mucopexy, same thing. Patient doesn't even know that surgery
That
has
is surgery
happened.
is done.
And it's a cure that is demonstrable on table. That is very, very interesting about it. So I think people should focus more on such morbid procedures for the public.
My
benefit of public.
experience also, I have had lots of patients coming and asking me, doubts about the utility of laser and hemorrhoids and all. So, doctor, what would your take be on that?
Basically, that was wonderful to listen the stories from you guys. But my take is little different. I mean, no matter how enthusiastic patient is, but we need to understand that whatever hybrid approach we have adopted, whether it is laser, cutis procedures, or some other surgery, the thing is, the procedure is same. We have applied or given similar amount of dissection, and we have cured the patient. So we have to respect the disease. Even if patient wants to go same evening and he's more than willing to drive 200 kilometers because he's not having pain. But the injury amount is same inside. So we need to educate them that hold their horses, respect the illness.
I agree.
So basically, this is which is more important.
Yes, sir.
And one more important thing, sir. With the ease of access of internet, almost every third patient in your OPD is coming up and demanding for laser.
Yeah.
We as an expert, we have to gain the trust of patient and give them the best choices. Laser is definitely very promising and upcoming, and it has made a revolutionary change in procto cases. But yes, it do have certain limitations. Like Dr. Sahu have actually mentioned that anything above dentate line is easy to cure, but below dentate line, we have limitations. So, selection of procedure, whether it is going to be laser, hemorrhoidal artery ligation, stapler, closed hemorrhoid, or maybe the classical surgery. It is a surgeon's choice and comfort. The aim should be to cure the patient, to treat the patient. Of course, if patient is coming at the right stage, laser has got a dramatic and magical effects. There is no doubt about it. I mean, I'm using laser since 2018. And so is true for stapler also. I mean, all these procedures are a real blessing to the patient and to the medical fraternity. But we have to choose the right patient, right therapy. Then only we can expect the best outcome. This is what I feel.
So, laser in hemorrhoids is a well-known fact.
Yeah.
What would your take be on laser in, say, fissures and in fistulas, for example? Is there any role, or would you say it is not?
I would not say there is no role, but very limited.
Very limited, yeah.
Yeah, very limited.
I will just add to that why it is limited. First thing is that in a fistula, first thing we have to, even if it looks from the outside is a lower fistula, still we have to confirm nowadays by the MRI.
Yes.
Because we don't know where the branch. You may do one another, after some time again you will come back with that. That is the most important thing we have to tell. I always tell my patients. So it may be a small one, but we have to have MRI. MRI will give us the idea. Then they ask you, it is 100%? I told that it is not, if it is one tract, it is not 100%. Nothing is 100%. Not even a simple surgery is also. We do 100%. We as a surgeon.
Enter in the world, sir.
Yeah.
The fistula recurrence is more than 20%.
Yeah.
I can
So
bet to
that
the
I
last dollar. There is no doubt.
Best modalities.
Best of the best
No,
modality.
why I tell? Because we know all that. We are going through a tract. We are not seeing it. There are now there is.
Yeah, it is difficult to calibrate the tract and
No, you're right. No,
Yes.
we can granulate the drug, but when you are withdrawing slowly into laser, we may sometimes leave a small place gap,
Right.
and that may cause the recurrence again. So I always tell the same thing. In this relation to the pyrenoidal sinus, also they come and ask the same thing. My answer is the same. So I have to say what, and you should be ready for a recurrence.
Right.
So
And the
then
patient
we have to
education
be
part is
advised
most
that
important.
is very, very important.
Yeah.
Because we cannot tell Umar Taiwa the way people tell here. Umar Taiwa means everything is fine. I think that is, I don't know, Arabic people. So that is the thing, my understanding. So I tell them, no. As a surgeon, we do 100% surgery. They tell no, how much percent do it? No surgeon do 99% also. Every surgeon will do 100% of his effort. So that is, the 100% doesn't count the outcome.
Yeah, especially in proctology.
You will have whatever. Any surgery has an outcome, not 100%.
Yeah.
That we have to know. So where it is, how much we take.
Since you have asked about laser and fissure,
Yeah.
posterior beyond is lateral venous sphincterotomy.
Yeah.
Right.
So we have a very good series of applying laser to get this done. Like people are ultimately they don't want any wound outside. They don't want much of pain. They don't want much of postoperative morbidity. So in terms of these things, laser we have found this as a very good tool in achieving lateral venous sphincterotomy with very little morbidity. So I think it has got a very good application in fissure as well. Yes.
In that aspect also, before the laser thing, I used to do closed lateral
Close swing.
not by knife. I usually use the cautery. The needle cautery I used to do, because other cautery may take a lot of your sphincter, which can have a temporary incontinence. So, and this is another thing, we have to also tell about the temporary incontinence to everybody.
Yeah.
Because we don't know. I have not seen anybody coming with except that one came with somewhere from else with the incontinence I saw here. Otherwise, I didn't see my patients coming with the incontinence. I have not done much since by here. Last maybe these 4 or 5 years I am doing anal surgery. Otherwise, I was in the mostly the hepatobiliary and all those things. And before that, in India sometimes, before coming to UK and all those things, I didn't do much of the, to be honest. Now I am doing, because the important thing is the people think anal surgery is very, very important, because anything you miss an anal area will give a long-term effect to you. So like if you miss when I do abscess drainage in the perianal area, I always tell them that please, if you did a constant discharge after that, it is a fistula, and which can occur in any abscess. And mostly if it is a ischiorectal also, or a large abscess. So people should be educated for that. That fistula can happen. They should not be surprised, oh, doctor, you did, and there is a fistula now. So these are the things we have to.
I want to add to that point that say, no discussion on any disease is complete without discussing the negative aspects. I think because people come with as we rightly said, people come with a lot of hope.
Yeah.
And they want immediate magical cure. Of course, we can give it with laser, with Shivate, whatever we can give the least morbid treatment for the patient. No doubt about it. But none of the treatment is without complications.
Yes.
There is a certain percentage of people who come back to it. This public should very clearly understand.
Yeah.
Negative
Not only
aspects
about
have to be
proctology, I'm
discussed,
talking
yeah.
in
But
general.
in general.
Yes.
And the proctology is more common because the lifestyle people forget.
Yeah.
Today you tell them, once they are okay, they forget everything. Even we
And
forget about
because
the
it is
public.
really not possible
Yeah.
to follow
No, no,
all those guidelines and
as
rules
much
which we
as
were
possible.
doing 2 days.
As much as possible.
Yes,
For
like-
like telling them high fiber diet. What we have to tell them? Most of the time I tell them, for the general public I tell, okay, first thing is that you take vegetables either brinjal, bhindi, or like those which is not
Specific,
deciduous,
yes,
or the any of the foliages like these palak, whatever we are using. These are the things will never be digested. So you take as much. Plus the salads, which the most of the Middle East countries, they put salads is so big on the table, but
Yes.
they will eat nothing.
Nothing.
It will be all going down to the
Garbage.
drain.
In this regard, another aspect is, when you advise the
Yeah.
importance of stressing on specifics is through this particular experience of mine, where I told a patient, okay, you should be on a vegetarian diet, take lots of vegetables and all. So once he came back, his constipation was still there. So I asked him, are you on a vegetarian diet? He said, yes, I'm on a vegetarian diet. When I asked deeper, it came out that he's taking a vegetarian diet, yes, but minus the vegetables. He's just taking the curry of all the vegetarian dishes, which serves no purpose.
No, only in that also they sometimes still. I stopped meat, fish, this and spices. They think spices is the cause of all this problem. I tell these are all bogus. You don't. You eat everything, but my focus is that you should eat more vegetables and water. Drink. That is the only focus you can do it.
And in true sense, sir, when we say lifestyle modification, that doesn't mean that for a short period of
Yeah.
time you start consuming
Yeah.
To be a
vegetables or
lifestyle
nothing.
It should
Yes.
go on.
When the lifestyle modification is, it should become part of your life.
Yeah.
Whatever you are consuming, be it a water
Doesn't
or
matter.
vegetable, you have to redesign in a way that so that you can continue for the rest of your life.
That's what
Then
is
only
important.
it makes sense.
So that is the main thing. Like even after the cholecystectomy, they come. Oh, I will not take food, fat, this, that. I told no. Then why we did cholecystectomy for
Yes.
you? But you should restrict your things. It's not that.
Should be controlled.
It is not that.
And
You,
see,
you should have
no
a
discussion.
balanced thing for everything. You can eat everything, but you have to balance it. That's all.
if you have to summarize today's
Yes.
I must say that we should give our patient the best of our knowledge and experience. Let us not experiment on something in which we are not trained in.
Yes.
yes, yes.
Yeah,
Right?
that's important.
Because the ultimate motive is to give
Give
the
the
benefit
best
to the
to the-
needful.
Yeah.
Exactly.
So,
We may summarize it.
summarize it. Final words.
Yes.
Can start.
Yeah,
So,
it's a
so
summary.
as the topic has been on piles and fissure, as the take-home message may be both more or less lifestyle diseases. So there is a lot of scope for lifestyle modification, especially diet and body weight, exercise. All this can be added in a correct mix so that we can to some extent prevent this. And once it happens, to reduce the progression of the disease also, these measures will be helpful. But if you want me to tell you about what is the exact cure, there is big scope for interventions in terms of surgery or minimal invasive surgery or whatever. So
As it suits to the
patient,
to
as
the
well as
patient
doctor
and the
doctor.
dog and the cost and the hospital availability. So, and which we have all the facilities available in our setup.
Yes, that is what which I
So
was
that
just-
is the most important thing.
And
We
that-
have all the facilities available. They can avail it. But our advice mostly will be that your lifestyle, which will reduce your problems coming to us.
which will never reduce the importance of surgery because
Completely.
it is again an anatomical problem.
Yes.
Yes.
So that the only method is to do surgery.
True.
Which form of surgery we have all the available
Available
methods with us. So
And I feel really very happy. Like at Badr Samaa, I'm glad that we have certain experienced doctors all across the branches, and we have all the latest advanced techniques and due expertise, and that too with worldwide competitive rates.
Yeah,
Yes.
that's right.
So I call upon public, and personally I call upon public to avail this niche morbid treatments for piles and fissure. And yes,
And
they
it should be
benefit. That's my
taken-
ultimate aim.
Yeah,
That's right.
and it should be taken as important for the public that they should understand it's a disease which can be tackled in any form.
Yes.
Tackled from any form, starting from the prevention to the lifestyle to the treatment and outcome.
So to conclude, I would say that the take-home message from this particular podcast is basically lifestyle modification. So take a lot of fiber, take a lot of water, exercise, And one important aspect is, I think there are better places to do your social media and in reading newspapers. Avoid doing it in the washroom.
Yes.
So
Okay.
thank you, everybody. And
Thank you so
hope
much.
the public benefits from this discussion. And I would like to thank Badr Samaa to have started this kind of an initiative for public awareness.
And also let us get the feedback
Yeah.
from the public.
Yeah,
Sure.
sure.
Thank you.
Okay. Thank you.
Thank you.
Thank you
Take
so
care.
much. Thank you.